cases, we usually advise caution for a longer duration till the whole thing heals.
Okay.
Otherwise, I admit my patients on day 2.
Okay. Sir, we have one more question. Many anesthetists practice pain anesthesia. Does it work for chronic pain?
See, depends. Like I told you, the purpose of this lecture is knowing the diagnosis, and then you decide the treatment. So now suppose someone has got a lumbar canal stenosis, which is gradually progressing. That's a pathology which can progress with time. No matter how much pain blocks you give. What do these people do in pain blocks? Even I do pain blocks. Is you inject a local anesthetic and a steroid around the nerve, in the spinal canal, in the caudal region. We inject steroid and a local anesthetic. So that can work if there is a specific pathology which can resolve by itself. So usually I always advise pain blocks for acute disc herniations. That's because the herniated disc can resolve itself and the pain will settle. So during that time when the patient has severe pain not managed by medicines, then we give a root block to take care of that severity of pain. In chronic conditions, I don't advise root blocks. There are some very rich patients who want something to be done, and then the surgeon will advise a root block, but they are not for clinical or scientific reasons, they are for commercial reasons. So many
Okay.
people do that, but scientifically in chronic conditions, root block doesn't have a big role.
Okay. Sir, in case of a lumbar canal stenosis, what is the success rate of surgical intervention? How successful it is?
That depends on how good the surgeon is.
Okay.
So in my hands, I have got excellent success. When I started my practice, I used to give the textbook picture where you tell the patient that 80% of times you will get relief, 20% of times you may not get relief. But over a period of time, as I have improved my surgical skills, I know how to do a thorough decompression, how to decompress the roots. I would say in my hands, if it's a typical lumbar canal stenosis with typical clinical symptoms and a matching radiological picture. So all these things should match. Your diagnosis should be based on a clinical picture which matches very well with your radiological picture. So if that is the case, then in my hands, I would say at least 95% people will get excellent relief of pain.
Okay. Okay. So we have one more question. Somebody has asked, when is the right time to refer a low back ache patient to a surgeon? What are the red flags that we should keep in mind?
Yeah, so red flags I'm covering in tomorrow's session. So I will
Okay.
take that question tomorrow if they are still not clear about it. I'm
Okay.
covering all the red flags, don't worry about
No problem, sir. Does spondylolisthesis, in a case of spondylolisthesis, only physiotherapy will help, or what is the important time to go for the surgery?
it. So always, see, spondylolisthesis will always have a long history, a very long history. If a patient comes with chronic low back pain of 20 years or so, let's say more than 2 or 3 years,
Hmm.
he is either a case of spondylolisthesis or he is a PSY patient, psychological.
Okay.
It's as like a typical chronic symptom. So in these cases, why do they sustain for such long durations? The listhesis may not progress. Many a times the listhesis settles down at some point. There are grades of listhesis, grade 1, 2, 3, 4. There's a Meierding's grading system which you can read anywhere in the textbook. So if the listhesis is not progressing, they might have on and off. Sometimes the listhesis progresses. There is significant instability. Now in all these patients, they typically have symptoms of some weeks. They'll have a few weeks of pain and then the pain gradually settles. This will be a long standing that once I had in 1990s, I had this back pain. Then for 3 or 4 years, I never had back pain. Then in 1995, I remember I had a severe back pain which lasted for 2 months or so. then I did some XYZ. I went to some babas and did some jada fuki and all those things, and then the pain settled. So all these are self-limiting pathologies. Whatever you do in that duration, you apply IFT, you apply your SWD, people go to homeopathy, Ayurvedic, something they do, and the pain has to settle because the pathology is self-limiting, and then they feel that thing settled the pain.
Okay.
So pathologies, they tend to have these episodes, and a stage comes when it becomes more of a continuous pain. In spite of physiotherapy, in spite of all the alternative medicines, they don't get relief, and their functions are significantly affected, and then we suggest surgery. So
Okay.
we don't sell them the surgery, they have to buy the surgery from us.
Okay. So now we'll take the last question for today. So somebody is asking, how early would you recommend physiotherapy post-op for POTS spine, keeping in mind the chances of spread of infection, knowing the primary focus would have been in the lung?
Yeah, so remember always, and you write it down, and even I tell this in my lectures to orthopedic surgeons, to general practitioners, to any clinician or layman, that tuberculosis is not a surgical disease. Tuberculosis is a medical problem. The bacteria, the tuberculosis bacteria will not go with any surgery. So why do we do surgery? Is to manage the complications of tuberculosis of spine, which include instability or progressive neurodeficit. Even static neurodeficit may not be an indication for surgery, or a gross neurodeficit where grade 1 or such high loss of power, then we recommend surgery for decompression and fixation. So tuberculosis is to be managed by TB medicines. When you give TB medicines, the disease gradually resolves. No matter where in your body the disease is, the medicines will take care of any focus anywhere in the body. The primary focus is always in the lungs, so that will be taken care of. Your secondary focus in the spine will be taken care of. uh, as far as rehab is concerned, I am covering that on my third lecture. But usually, we are not very aggressive in rehabilitating TB spine patients. We give their TB lesions some time to heal, and then be more aggressive about the rehab part. Till that time, we give them some gentle exercises and those things. So
Okay.
I think I answered that question, or he has any more doubt, he or she, we can discuss it further.
Okay. I think, sir, that'll be all for today. And I would like to ask you one question. What are your expectations that we should study for next lecture? We should be thorough with some things.
Yeah, so the next lecture, as I told you, I think I showed my list what I'm covering in my next lecture. So, give me a moment. So we were studying the causes of back pain. So today we covered degenerative, SI joint, infection, osteoporotic, and tumor as the causes of low back pain. Tomorrow we will be covering deformity, arthritis, which includes Angst-Pond rheumatoid arthritis, metabolic causes, which is the most common cause. Everybody sees these patients. They are the most affording patients. All IT people, they come with this cause of low back pain, metabolic. Then trauma, where there is a big role of the physiotherapist. And if I can, I mean, in Pune, I don't know anyone who does good rehab for these quadriplegics and paraplegics. There, I think there are only one or two guys who are doing that. So we are in desperate need of people who can rehabilitate quadriplegics and paraplegics. So this is
Okay.
a huge area, huge
Yeah.
area.
Okay.
And then emergencies and urgencies where you have to refer.
Okay.
So these are the things. So deformity, arthritis, metabolic, trauma, and emergencies and urgencies.
Okay.
So this will be covering tomorrow. You can read whatever. If
ठीक है.
anyone has any more questions, for like they didn't get a chance to ask today, they can ask tomorrow. No problem. I'll try to cover tomorrow's topic in a slightly shorter duration if
Nice, sir.
possible.
This was perfectly fine. All the topics were covered fine, and we are
Yeah,
basically on
time.
time. Yeah. So I think, sir, that was very much it. And thank you for your time. And I guess the lecture was very interesting. And plus, we have already taken care of all the doubts, all the questions which were asked. So I think till the next lecture, we'll see you in the next lecture, I guess, then. Till the time,
Yeah,
I'll just make them study, and whatever doubts they have, they can just write it on a piece of paper, so
yeah,
that we can have a very good discussion on probably the last day or whatever day it is. But we'll just
yeah.
make sure to make it more informative and more interactive. Okay?
Yeah, I think we will cover most of the questions. No one should feel left out.
Definitely, sir.
These questions must be answered because it's not about what I am teaching. It's what about what people want to know.
Yeah.
So if I'm just going on speaking something and they want to know something else, that's what I need to know. That
Yes, sir. And that is the
so that,
bridge, sir, which we want to, that is the gap which we want to cover. So definitely we'll try to work on that point as well.
yeah.
Okay?
So
So
tomorrow's will be again this low back pain remaining topics like the Thursday thing, and then
Thursday thing.
Friday having
Yeah.
post-op rehab of a spine patient, which will be
Okay.
very interesting topic.
Okay.
What we expect from a physio.
ठीक है. ठीक है, sir. We'll see each other on Thursday then. And let
Yeah.
us hope everybody will definitely study and come. And let's hope. Okay. Thank you, sir.
Okay.
Thank you for your time. It was very nice having you. And let's hope the next lecture is much more interesting. Okay.
Sure.
Thank you, sir.
Thank you.
Thank you for your time. Please take care.